In a consultant-level surgical viva, examiners grade the candidate on their systematic approach, prioritizing a structured evaluation over an immediate diagnosis. This environment demands that every clinical decision be supported by a progressive gathering of evidence. The scenario begins with a 79-year-old female patient. She has a 3-day history of progressive abdominal distension and obstipation, an absolute inability to pass either stool or gas. She has no previous surgical history, nor her mental status has been steadily declining over the last few years. This clinical data dashboard isolates the patient's vital signs. While her blood pressure, respiratory rate, and temperature of 36.8 degrees are stable, her heart rate is elevated at 108 beats per minute. That isolated tachycardia acts as a clear physiological stress indicator. The examiner now evaluates if the candidate will pause to gather missing history or attempt to jump to a conclusion based on the distension alone. The candidate must request specific historical details to clarify the presentation. They need to establish the exact nature of the abdominal pain, specifically whether it is colicky, and ask if there is an active history of vomiting. On the physical exam, the candidate needs to confirm findings that suggest a mechanical obstruction. Specifically, they must identify a tympanic, drum-like sound upon percussion of the abdomen, accompanied by hyperactive bowel sounds on auscultation. This diagnostic decision tree maps out the physical exam pathways. An empty rectum finding acts as a critical divergence point. Confirming the rectal vault is empty isolates a complete mechanical obstruction from general functional dysmotility. With this data, the differential diagnosis narrows to 4 distinct possibilities: large bowel obstruction, a sigmoid volvulus, a sigmoid tumor, or Ogilvie syndrome. Establishing this structured baseline of history and physical data anchors the investigation to objective findings. This methodical approach prevents the oversight of secondary pathologies when evaluating an acute abdomen. The investigation phase starts by ruling out metabolic causes of an ileus. The candidate must order baseline lab work, including a CBC, urea and electrolytes, and liver function tests. The examiner confirms that all lab results are within normal limits. This eliminates metabolic imbalances as a cause and shifts the diagnostic focus entirely to radiological imaging. This schematic traces the geometric outline of the abdominal cavity based on a preliminary X-ray. It displays the bent inner tube sign, where a massively dilated loop of the colon projects toward the right upper quadrant. While the X-ray is highly suggestive, the examiner expects the candidate to request a CT scan of the abdomen. This provides the cross-sectional detail required for definitive surgical planning. This axial cross-section graphic highlights the pathognomic CT finding. At the mesenteric root, a distinct spiral pattern forms a mesenteric swirl. This confirms a closed-loop obstruction. As the bowel twists, it mechanically pinches off the vascular supply to the trapped segment. A CT scan provides the definitive anatomical proof needed to rule out active ischemia and perforation before the surgical team attempts any physical intervention. By proving the colon's blood supply remains intact and the bowel wall is not ruptured, the imaging confirms the anatomy is stable enough to proceed with non-operative decompression. The examiner then introduces a pivot question regarding the initial treatment plan. Once the diagnosis is confirmed, how should the team proceed? Before initiating any mechanical procedure, the mandatory first step is aggressive intravenous fluid resuscitation to stabilize the patient's circulatory volume. Once resuscitated, the core intervention is endoscopic detorsion, physically untwisting the bowel from the inside. This comparison contrasts the physical capabilities of rigid proctosigmoidoscopy versus flexible sigmoidoscopy. Rigid scopes have a maximum length of 25 centimeters. Since 24% of torsions occur more proximally, they remain out of reach for a rigid scope. Despite the length limitation, rigid scopes offer a structural advantage. Their design allows the surgeon to pass a rectal tube directly through the inside of the scope to stent the bowel and prevent short-term retorsion. Flexible sigmoidoscopies provide superior reach and improved visualization. This allows the endoscopist to carefully inspect the colonic mucosa and assess the tissue viability of the proximal colon. If the endoscopy reveals necrotic tissue or actively bleeding mucosa, the decompression must be aborted immediately, and the patient must be taken to the operating room for emergency surgery. Successful endoscopic decompression changes the patient's risk profile. It converts a high-mortality surgical emergency into a controlled situation, allowing the team to optimize the patient's health before performing a definitive operation. The examiner will then challenge the candidate to explain why decompression alone is clinically insufficient for long-term survival. This schematic diagram details the underlying anatomical defect. The patient has a highly redundant, elongated colon section anchored to an abnormally narrow mesenteric base. This 3D model demonstrates the mechanical action at play. With a long bowel and a narrow anchor point, the redundant colon easily twists over itself. In 70% of cases, this twist occurs in a counterclockwise direction, creating a strangulation point. Endoscopy only resolves the immediate twist. With the elongated mesentery and narrow base unchanged, the patient is certain to face a recurrence of the volvulus if the anatomy is not corrected. To permanently resolve the condition, the definitive surgical intervention is an elective sigmoid colectomy, where the redundant section of the bowel is resected. Performing this colectomy during the elective phase is a strategic choice. Operating on a decompressed bowel allows for a primary anastomosis, reconnecting the healthy ends of the colon, avoiding the risks associated with emergency surgery on dilated, unprepared tissue. The candidate must also reject sigmoid pexy. Simply suturing the redundant bowel to the abdominal wall carries an unacceptably high recurrence rate and fails to address the anatomical excess. Definitive surgical resection is the only acceptable endpoint because it physically removes the anatomical defect responsible for the twist. The viva scenario concludes with the post-operative care phase, ensuring the candidate can manage the patient safely through recovery. Standard enhanced recovery after surgery parameters apply. The candidate must specify the use of venous thromboembolism prophylaxis to prevent blood clots, alongside early mobilization. Clinically, the surgical team must rigorously monitor the patient for any signs of an anastomotic leak, where the newly reconnected bowel segments fail to seal properly. Finally, candidate must review the post-operative histopathology report of the resected tissue. Examining the specimen under a microscope is the only way to rule out an underlying malignancy hidden within the twisted segment. The complete clinical pathway requires a sequential execution: resuscitate the patient, image the abdomen, endoscopically decompress the bowel, optimize the patient's health, and surgically resect the anatomy. The consultant-level candidate demonstrates the judgment required to safely de-escalate an acute crisis, map the underlying anatomy, and deliver a definitive, permanent cure.